Hello, everyone. I would like to thank Dr. Crosta and the organizing committee for the kind invitation to participate in this Congress. And I'm so sorry to not be there in person. I had a horrible, severe allergy to shellfish that left me very, very ill a couple of days ago. So I just wasn't in good shape to fly. So thank you for being understanding and allowing me to provide you with this pre-recorded talk. And I look forward to the discussion with the panel. I'm going to go ahead and start and share my screen. And we're going to talk about pedal acceleration time, the measurement and technique, where to measure, how to measure. And really, this is a topic that is near and dear to my heart. And so with that said, I'd like to provide you a historical vignette of pedal acceleration time. In 2017, I ran a limb salvage program and worked closely with vascular surgeons. I've been doing vascular ultrasound for 25 years and have the privilege to be taught by my esteemed colleagues in vascular surgery team. And really, as a vascular ultrasound specialist, I got really tired of not being able to tell them what the perfusion was like in the foot because patients like this cannot undergo toe pressure. The ABI is not reliable. Therefore, this led to me scanning my own foot in 2017 and realizing that we could see these vessels in the foot with ultrasound very well. And that really was the opening of so much opportunity and discovery of pedal acceleration time. And I have to thank my colleague here, Dr. Desirome Tesso. He's a vascular surgeon that I work closely with in all of the discovery of pedal acceleration time. Together, we looked at waveform analysis, ratios, flow volume, waveform analysis, but really we found that acceleration time was the most sensitive and specific. And in 2017, together, we did our first case where we showed a real-time change of pedal acceleration time on the table. And it was very exciting. And we realized that this really could be something that could benefit patients from unnecessary amputation. So I'd like to thank him for really teaming up with me and believing in something new and the discovery. So fast forward to 2018, we published our work in the Journal for Vascular Ultrasound on really how to perform this examination and what the arteries were that we could see with duplex ultrasound. In 2019, we published our criteria in the Annals of Vascular Surgery, and this was reflective of 499 limbs. These patients were non-diabetic, non-renal failure patients, and we felt that ABIs were reliable to compare it to PAT. So PAT not only correlates nicely with ABIs, but also with clinical symptoms. PAT is broken up into 4 classifications, class 1 being normal, all the way to class 4 being consistent with tissue loss and rest pain. And that year, I reached out on Twitter and really wanted to talk about it with the medical community in vascular Twitter. And this is where Dr. Montero Baker invited me to Mexico to speak at Hendelet on pedal acceleration time. And I'm very grateful for this opportunity. And this really launched the relationship with South America and North America to really understand and teach pedal acceleration time. And of course, Dr. Mignola was also very helpful in allowing that opportunity for me. And from there, it really has been a global effort. And as you can see, your flag is on there because I met Dr. Abib, who is probably in the audience. And I taught him on Zoom over before the pandemic, actually. And so really PAT has been a global collaboration, which is really exciting. So fast forward all the way till 2024, and we have a number of articles published on this work. And and even in 2024, we have many new articles, specifically looking at the correlation of PAT and TCPO2. That was in collaboration with our colleagues in Portugal. So I urge you to read these articles if you have access to them. I can also share them. And then we were also had a small paragraph in the Woundosome paper, which was a global effort by Dr. Petrone. And this was 187 global authors talking about the woundosome in CLTI patients. So PAT really is becoming well known globally. And then, of course, doing a lot of PAT workshops. We were going to do one in Argentina, but unfortunately, I'm not there. But it is exciting to be present in so many countries. So where are we now? I think we continue to do global education and workshops and publications. We've come a long ways. And I think the goal is to become in the global guidelines for Wi-Fi. And so we'll keep working and to get to that point. But for now, I would like to say, just do it. This is a technique that can be very helpful. And I am available if any of you want to Zoom or learn virtually. I've done it all over the world, and it's proved to be reliable and very helpful and fruitful for your practice, especially in patients like this where the current technologies that we have are not helpful. So let's talk about pedal acceleration time. We've gone over the criteria. This is just the extension of the arterial duplex in the foot using a standard linear probe that we use for carotid ultrasound. And Dr. Montero puts it very well. We should always start with ultrasound. So I encourage you to start looking at the foot first. And as you can see in these examples, right away, we know if a patient has a neuropathic diabetic foot wound, PAT is class 1, versus a neuroischemic. This patient clearly has ischemia. This is class 4 PAT. And you can easily distinguish the difference between the acceleration time from this waveform to this waveform. So when we perform our arterial duplex of the limb, we can now scan below the level of the ankle and really map out the target artery pathway of the blood flow. Of course, we're going to take care of this popliteal artery occlusion. However, because of the occluded dorsalis pedis, arcuate, and first dorsal metatarsal artery, perhaps we need to get blood flow to the digits indirectly through the plantar circulation. And I think the addition of pedal duplex helps us understand how we're going to get blood flow to that wound bed. So this is a step-by-step guide. I'm going to provide you also with the QR code that you can reference and take it back with you. But let's break this down. This is the anatomy that we can see by duplex ultrasound. So we have the dorsalis pedis artery, the bifurcation of the arcuate, first dorsal metatarsal artery. And on the plantar circulation, we have the medial lateral plantar and the deep plantar to make the complete pedal arch. There's also a superficial arch from the medial tarsal to the medial plantar, but by and large, a lot of patients have the complete pedal arch. There's a lot more anatomical variations on the top of the foot than the bottom of the foot, so we have to be thoughtful. If we do not see a dorsalis pedis artery, we have to look for the lateral tarsal artery and the medial tarsal artery because they may be a pathway to get blood flow to the digits. When we look at the plantar circulation, I really like the medial plantar in the setting of a first metatarsal non-healing wound. And we can also evaluate the plantar metatarsal arteries going out to the digits. So this is what you'll see angiographically. Lateral foot shot, we can see this very well, not only angiographically, but also with ultrasound. And I think this highlights that we can understand the hemodynamics, but this is a subjective look at perfusion to the foot, where PAT is an objective number that quantifies perfusion. So I like this diagram to help understand the pedal flow hemodynamics. But let's talk about the step-by-step process. So if I was there in person, this is how I would teach it to you, is you are now going to put the probe on the top of the foot between the first and the second toe. There's a soft tissue window called the cuneiform bone or cuneiform window, and you're going to put your probe right at the top of the cuneiform bone on the top of the foot. From here, we're going to use no color. We're going to image the cuneiform bone and see the medial marginal vein. We will see no bone on the right-hand side of the screen. Once you see these landmarks, we're now going to apply color. On your ultrasound system, you're going to decrease your color scale and make your box really small around the vasculature. So already here, based on the flow direction, we have antegrade flow in the distal dorsalis pedis artery with retrograde flow coming in the arcuate artery from the plantar circulation. This tells us that the pedal arch is intact. And then we have antegrade flow in the first dorsal metatarsal artery going to the wound bed. So this picture tells us a lot. It tells us about anatomy, flow direction, and calcium burden. We have pretty good color filling, therefore, the calcium burden in this patient is pretty low. From here, we'll put our Doppler in the arcuate artery, we'll angle correct, and then because the flow is retrograde, we're going to leave the blood flow below the line. We're going to raise our baseline up, and we're going to make our waveform really big so we can accurately measure from the onset of systole to the peak of systole to obtain this acceleration time, which is 83. That is class 1 PAT. Without moving your probe, you're now going to place the sample volume of the Doppler in the first dorsal metatarsal artery and measure a PAT in this vessel to the great toe. This is the easiest window to image the anterior circulation. So now let's go on to the plantar circulation. I'd like you to put your probe in a transverse view on the midfoot. And from here, you'll line the probe up with the fourth toe, and you're going to see landmarks, which are the metatarsal bone, the lateral plantar veins, and you're going to start compressing the probe on the patient's foot so we can see the veins closing around the artery. From here, you're going to turn the probe in a long axis view, and you're going to line your probe up with the fourth toe. From here, the indicator on the probe, the notch, is going to go towards the heel, and you're going to decrease your color scale, and you're going to use the veins as your landmark. From here, you'll put your sample volume in the lateral plantar artery and obtain an acceleration time. It's very simple. From here, you're going to slide your probe to the ball of the foot. Now, if there's no toes, you can put the probe at the base of the wound and see this nice lateral plantar artery. Here's the plantar vein. So once you slide the probe to the ball of the foot, you'll see the deep plantar artery start to dive, and this is where it's going to meet the arcuate artery. Now from here, we're going to look at the medial portion of the foot right at the base of the metatarsal head. And this is where we'll see the hallucis longus tendon and see the medial plantar more superficial. For success, you want to make sure your color scale and Doppler are low. Pedal velocities range from 15 to 28 in the foot, so just lower your color scale. And then make sure, this is the most important part of this whole talk, is that your technique is correct. So we're going to lower the baseline down, increase your sweep speed, and you're going to make your waveform really big. So we want to accurately measure from the onset of systole to the peak. If your waveform is really tiny, the accuracy will not be as good. So we want to make the waveform really, really big. And then we're going to apply that acceleration time to our published criteria. So PAT tells us the perfusion in the foot, but we can also look at anatomy and flow direction. And the flow direction is really important, especially if we have to do indirect revascularization on these patients. These are patients we see in our vascular lab in practice. These are patients that cannot undergo ABIs or TBIs. So these are patients that I feel PAT is very, very helpful. And just to give you an example, if you put a probe on this patient, this patient's hemoglobin A1C is 12. This is a neuropathic foot wound. The PAT is class 1. This patient automatically is class 4. This is neuroischemic. So right away, we know that what the perfusion status is like to the wound. Now, PAT is not perfect. There are limitations, so let's review them. In the setting of isolated, hemodynamically significant iliac disease, you cannot rely on PAT if everything from the groin down is open. The flow in the foot will just be really low. And a PAT of greater than 300 is automatically class 4. Number 3, this is the most important. If the velocity in the foot is 5 centimeters per second or less, that is class 4 PAT. And there's always variability between operators, and then we need to know more about low cardiac output, especially below 20%. So here's a good example of a patient on the left that has a cardiac output of 15%. And then the patient on the right has ischemic rest pain. Both have very low perfusion in the foot, but they represent different things. And we just can't measure PAT accurately. Pedal flow hemodynamics, I think, is really exciting because we now can understand flow direction. So if you have a retrograde arcuate artery flow pattern, you know that the arch is intact. And I love this because if there's a great toe wound and you cannot open up this intertibial or dorsalis pedis, we have to indirectly get blood flow to the great toe. And we can see that by ultrasound. And this is what it looks like. We have the red foot perforating vein. We have the retrograde arcuate. And when we pause this, this medial marginal vein foot perforating vein is our landmark. And then right away here, we can see the hemodynamic pattern. Antegrade dorsalis pedis, retrograde arcuate, and antegrade dorsal metatarsal artery. So just be on the lookout for that flow direction pattern. The same thing occurs in the lateral plantar artery. If the lateral plantar artery is retrograde, this tells us that the arch is intact and that there is likely significant disease in the posterior tibial artery. And so we would want to measure the waveform below the line to measure an acceleration time. So I like these diagrams because they tell us a lot about pedal flow hemodynamics and the communicating arteries from the perineal artery. So in the setting of an occluded posterior tibial artery, if the lateral plantar artery is antegrade, we know that the communicating arteries are open from the perineal. Same thing with the anterior circulation. If the posterior tibial artery is occluded, and maybe the anterior tibial artery has disease with antegrade arcuate artery, we know that the perfusion is coming from the perineal. This is my favorite, single vessel runoff from the perineal with robust collaterals. So let's give some examples of where to measure and how. So this is looking right at the cuneiform window. Obviously, there's a toe amputation here, but we can easily see flow in the distal dorsalis pedis first dorsal metatarsal artery to that healed wound bed with class 1 PAT. And even in the setting of high calcium burden, we can still image these vessels. And here's a good example of the use of the medial plantar artery in the setting of a wound like this. Put your probe right at the base of the wound, and we'll see the hallucis longus tendon with the medial plantar right above it, class 1 PAT. This is neuropathic. And then here, this patient has a complete arch that was not cut for the transmetatarsal amputation. Sorry, it's antegrade here. And you can easily see the lateral plantar artery and vein. And then in this situation, this is retrograde flow coming around the arch, going backwards towards the heel in the lateral plantar artery. So look how nicely we can see some of these vessels. It really is a nice tool. So let's quickly go over a case. This is a 68-year-old female. She presented to the emergency department with bilateral toe gangrene. All the typical comorbidities with absent common femoral pop and pedal pulses. Her ABIs were unreliable. We could not obtain toe pressure, and her PAT was class 1 bilaterally. She had a CT that showed bilateral iliac disease and common femoral stenosis. So she had staged procedures. They did a bilateral cut down, common femoral endarterectomy with patch angioplasty, and kissing iliac stents. We staged the procedure and then did bilateral femboloni popliteal bypass using vein. So on the left, pre-procedure, she was class 4. After all of her procedures, she went to class 1. And in this situation, she has 2 vessel runoff in the posterior tibial and perineal artery. So for her arcuate artery is retrograde with flow going towards her TMA site. And her flow is class 1. On the other side, also staged procedure, went from class 4 to class 1. And this side, she has 3 vessel runoff. And you can see the nice tissue granulation, and she's healing very well. So we follow our patients with ultrasound and PAT throughout the course of wound healing. And she was doing very well until her wounds stalled. This was starting to not heal, and this was starting to open up. So I start with PAT, and it's automatically class 4 now on the left. So she has a high-grade stenosis in her distal anastomosis on the left. And on the right, her PAT is class 3. So she also has a stenosis in her distal anastomosis. So we did brachial access, cut down, and did bilateral balloon angioplasty of the distal anastomosis of the bilateral fem pop, and cleaned her wounds up. And now she is back to class 1 PAT bilaterally. And she did very well. She went on to heal both of her wounds, was fitted for shoes, and was able to walk out with avoiding amputation above the ankle. So a very good use of pedal acceleration time. So the application extends beyond just CLTI. I think there's a need for it in mixed disease with venous and arterial disease. And then we certainly can use it for our claudicants in exercise program. And that's a whole nother talk. But for now, I will say thank you very much for your time and attention. Hi SBU, I am going to perform a live demonstration of how we scan the pedal vessels and how we apply our novel technique called pedal acceleration time. We'll begin with the arcuate and dorsal metatarsal artery. Now you can choose to use the linear probe or the high frequency hockey stick probe depending on the patient's foot. If it's a thinner foot, the hockey stick really is recommended. For this training purposes, we'll demonstrate both. So we're going to start by using the linear probe. And we're We want to make sure that the indicator is towards the patient's head. We are all familiar with the distal anterior tibial artery and the dorsalis pedis artery, so we will continue scanning distally towards the foot. By placing the probe on the top of the foot, we want to apply light probe pressure because these vessels are very superficial. There's a robust arcuate artery with the beginning of the dorsal metatarsal artery right here coming towards the probe. And we'll go ahead and angle correct to obtain the arcuate artery. My sweep speed is already at medium, or we see 3 to 4 cardiac cycles. And then from here, we'll measure the onset of systole to the peak of systole. And the acceleration time here is normal at 52 milliseconds. So this is the distal dorsalis pedis artery, and this is the origin of the dorsal metatarsal artery, and the arcuate artery is diving down. Let me pan to my hand. You might go here. We can tell that flow going away from the probe is red, so we know this blood flow is normally directed towards the plantar circulation. So this would be an antegrade arcuate artery. Because this dorsal metatarsal artery is so superficial and a little bit difficult to follow with the linear probe, I'm going to switch to the hockey stick probe. I've now switched to the high frequency hockey stick probe, and now we can image the dorsal metatarsal artery. So we'll find the arcuate artery. Invert my color. So we've located the arcuate artery, and then there's that dorsal metatarsal artery, very superficial. I'm optimizing my image, decreasing my color scale, increasing my gain, and you can follow this dorsal metatarsal artery. I'm right at the base of the great toe. And again, with light probe pressure. Here's the dorsal metatarsal artery. Measuring the onset of systole to the peak of systole. It's okay to overgain your waveform so you can precisely measure that acceleration time. We're imaging the posterior circulation of the foot. The medial plantar would be more medial on the foot, while the lateral plantar would go more of the midfoot, and then the deep plantar would be right at the base of the ball of the foot. So a lot of people ask, do we scan this territory of the common plantar to the bifurcation of the medial and lateral plantar? And the answer is you can, but we do not, because the vessels dive deep in this territory. So once you image the distal posterior tibial and the common plantar, you can pick up the probe from here and go straight to the bottom of the foot. You can go in transverse and see the plantar veins. And we can compress the plantar veins with the lateral plantar artery right here, and we're using this metatarsal bone as our landmark, so we know that's the lateral plantar artery. And from here, the indicator will go towards the heel. And if you look close enough, let me see if I can do max view here. If you look close enough, you can see the pulsating lateral plantar artery. So we're going to optimize our image. go. So image optimization is really helpful. You have to be just a little bit patient to bring in the vessel. So this lateral plantar artery is normally directed. And then if you question at all, you can do a foot squeeze and you can see flow in the lateral plantar vein as your landmark. So I'm on max view, so my sweep speed is really long, but we still want to decrease the scale. And measure the onset of systole once again to the peak of systole. And the PAT is 56 milliseconds. From this view of the lateral plantar, we're going to slide the probe just to the ball of the foot, turn our color box, and here's the deep plantar vein with retrograde flow in the deep plantar artery. And what that tells us is that in his foot, his anterior circulation is dominant, so it's trying to wrap around the foot, and maybe there's some poor continuity in the mid-lateral plantar artery, so we have competitive flow. So the deep plantar artery is retrograde. If I compress the anterior tibial artery, it may go retrograde. Yep. So it's now almost multiphasic, but my scale is too large. Hang on. There we go. So this tells us that the anterior circulation is dominant. And then when I release, it goes back to being retrograde. So we proved that this was the lateral plantar, and here's the deep plantar. Now we're going to take our probe back to the midfoot. The indicator of the probe is still towards the heel, and then we're going to slide the probe just a little bit medial. And we should expect the medial plantar to be more superficial, coming towards the probe. Got to fish for it just a little bit. There we go. There we go. Sometimes it takes just a little bit of investigation and time to locate these small pedal vessels, but here's the medial plantar artery. We don't see the metatarsal bone as our landmark, and our probe is placed more medially, so we can confirm that we're likely on the medial plantar artery. I'm going to go back to the normal view here. So our sweep speed is at medium. We have 4 cardiac cycles, and then we can precisely measure the onset of systole to the peak of systole. So some people ask about waveform selection and where we would measure PAT. My colleague Brooke is doing a great job videoing me right now, and she may measure the PAT in this waveform, and I may measure it in this waveform. But the acceleration time is in the same category. We have a 40 millisecond PAT and a 56. So we're still in the same classification. So like anything we do, there's always tech-to-tech variability, and we want to ensure that we are consistent in our vascular lab. You ready? This is a delightful 66-year-old female. She's a type 2 diabetic and a previous smoker. She originally presented with bilateral foot gangrene and underwent staged procedures of bilateral common iliac artery kissing stents, bilateral common femoral endarterectomy, bilateral fem-popliteal bypass grafts, and bilateral forefoot amputations. PAT preoperatively was greater than 300 milliseconds bilaterally, and postoperatively now is in a class 1 territory. So this is our follow-up duplex that we follow these patients throughout the course of wound healing. We are looking at the anterior surface of the skin here.
imaging the dorsal metatarsal artery with the superficial hockey stick probe. And so when we put on color here, you can see the dorsal metatarsal artery going towards the amputation site. And then when we put on Doppler ultrasound, increase our sweep speed, we can measure the pedal acceleration time
of 104 milliseconds, and this is going right to the edge of the amputation site. But now let's pause for a second and really appreciate just how well we can visualize this anatomy. You can see the distal DP bifurcating into the arcuate artery and dorsal metatarsal artery. Now let's move on to imaging the bottom of the foot. We're going to use a linear probe with the indicator towards the heel. We'll first image the medial plantar artery, which lies more medial on the bottom of the foot, and the vasculature is more superficial underneath the skin. You can see her medial plantar artery quite well here. We're going to apply the same technique for PAT. We're going to decrease our scale, increase our sweep speed, and measure the PAT, which is also 104 milliseconds in her medial plantar artery. Now we are going to just do a very slight sweep of the probe towards the midfoot to image the lateral plantar artery, which is deeper than the medial plantar artery. We can use the lateral plantar veins as our guide, and we're going to apply the same technique as we did with the other vessels in the pedal arch by measuring the PAT. And in this case, the PAT measures 84 milliseconds in the lateral plantar artery. We're now going to look at the arcuate artery in the right foot. You can see the hockey stick probe on the surface of the skin. So here's the arcuate artery. Flow is normally directed to the bottom of the foot. Can measure her acceleration time, which is 120 milliseconds. You can see this test is really valuable because in a patient who's had bilateral transmet amputations, doing surveillance using PAT can be a valuable data point to show that the perfusion to the foot is adequate for wound healing. Now, some of you may ask about the abnormal monophasic continuous waveform, even though the PAT is presenting as normal. But remember, in the diabetic and renal failure patients, the vessels lose their compliancy, so the waveforms really remain sort of abnormal appearing. All we're really concerned about is that pedal acceleration time. And if we refer to our criteria here, we want to remember that less than 120 milliseconds is considered normal, and greater than 225 milliseconds is consistent with tissue loss and rest pain. This next case is a 57-year-old long-time diabetic patient that presented with gangrene. Orthopedic surgery did a first-rate amputation, and the preoperative duplex showed a pedal acceleration time of greater than 225 milliseconds. So this is where I love to be, which is in the cath lab, and we can show real-time improvement in PAT. So this is looking at the PAT before the patient is prepped and draped, and you can see the dorsal metatarsal artery is abnormal with a PAT of 256. After the patient had balloon angioplasty of his posterior tibial and anterior tibial artery, and we see a real-time look at PAT, it improved from 256 to 136 milliseconds post-intervention, and this was a great result. We can really appreciate the side-by-side comparison of the PAT pre and post here, immediate real-time response. And then we saw the patient post-operatively 30 days later, and you can see the wound is starting to heal. We can image the dorsal metatarsal artery right at the wound edge and see that the PAT is remaining at 136 milliseconds. We can also see his beautiful medial plantar artery that goes all the way to the base of that amputation site as well, with a PAT of 80 milliseconds. We scanned him at his 6-month follow-up appointment, and as you can see, his wound is completely healed. He has normal class 1 pedal acceleration time on the anterior and posterior circulation of his foot, which is a fantastic result. Jill, something so great. Check this out.
Oh my god, that looks amazing. That looks so good.
Cool. So the acceleration time went to 129, which was nothing before. Same spot, the medial time for right to the end of the movement.
That's so awesome. The AT, but if we can't get across, then we know we're still good.
Yep. PAT prior to the perineal intervention, and then we see a real-time improvement to 129 post on the table changes, which is pretty great.
Jilly,
Yes.
will you make sure that's in the perineal? Okie dokie, artichoke. We'll take a 2.530. Ooh, that's good. Hold it there. Just like 30 seconds or something.
And then you see the velocity kind of decrease down. What balloon is this?
Yeah, 3. Same. So we know how significant this lesion is. And like, we know where all the money is on this foot.
139. And that was just a balloon with the balloon of the TPT.
That is insane. Okay. Okay, PAT people. That is why it's so insane. That's the beauty of PAT. 139 from 255 with just that little balloon.
By ultrasound, that TPT I think was pretty tight. So it's hemodynamically significant.
And this is where angio doesn't really tell you. Like you can look at that angio and be like, oh.
So can you guys appreciate the pulsatility of this color Doppler as well? We're already seeing changes in the pulsatility before. The color was just like almost constant. Yeah, 128. We're all in that same classification.
Is that at his wound?
Oh yeah, just right in the medial plantar.
Oh, okay. So yeah, so we're Dunsky.
Mm-hmm.
So this is the benefit of ultrasound. Like I basically have a crappy angio from the knee down post. So I can spend more time selecting out every to prove, to document that it's all well, or we can do this.
Other things, because I see she's doing a lot more than just measuring PAT for you.
Oh, totally. Yeah. So like if I need confirmation, like I could be doing something over here where I'm like, hey, tell me if I'm in the perineal. But you need somebody who's quick and understands the anatomy. And I'm like, why are in the perineal? She jumps in there. Because I certainly am not going to stand around while some junior level ultrasound tech tries to figure out how to image the perineal, you know. And that's where like your level, Jill level person. But there are also other ways. Can we move this down to do the foot? There are other ways to do that. It's just because I have such a highly skilled person standing here, I'm going to use all the tools I have. Look at that foot perfusion. Oh, yes. Oh, wait.
I know, right?
We usually do air high fives, even when we're sterile. That looks so
Okay.
good. You see the womb blast? So, like, the angio result is really good.
Hello, now we are going to talk about the decision making utilizing pedal acceleration time. So we know that time is tissue, and we really can't sit on these patients. You can almost see the story play out in front of your eyes. This second picture was taken just a week after this initial image, and this patient then went on to heal a 4-foot amputation. But we just can't delay treatment for these CLTI patients. I like how Dr. Montero Baker thinks. We prep really well for AAA repair, whether it be open or endo. And I think we should also be prepping for arterial intervention. And therefore, I think we can use ultrasound to create this roadmap. Oftentimes people get a CT, but I think infrapopliteal and below the ankle disease warrants the use of arterial duplex ultrasound to really understand the target artery pathway and the level of the disease and really your plan for intervention. So we have all of these tools to assess perfusion, and I'm just saying that pedal acceleration time is just an additional tool that we have now in our repertoire to use in certain patient population. I think there's still a utility for ABIs and TCPO2. However, in some complex patients, really PAT can be super helpful. And in this type of disease pattern, you can almost predict where the disease is going to be. So in the United States, I like to teach to take a complete history of a patient. We know a non-smoker, diabetic, maybe with renal failure, is going to have infrapopliteal and infra-ankle disease. So in the United States, we like to take a full history, always undress the wound, and I start the ultrasound at the wound bed. And this really tells you if you are mapping for intervention or not. So in this situation, I'm going to go to this lateral tarsal artery and even the fourth dorsal metatarsal artery to understand what the perfusion is like. And I think this patient has regional ischemia to this fifth toe wound. This is a watershed area. So flow on the plantar aspect of the foot is class 4 PAT, and it's also class 4 PAT to the wound bed. And if we look closer here, the PAT to the great toe is class 1. So this just tells us we have to utilize the PAT value at the wound bed. And this technique, these are our patients, and I think that the use of PAT can be so helpful in your decision making, especially maybe when we have mixed disease and you can't put a blood pressure cuff over the ankle. So just to recap, we're going to apply our criteria to the published criteria of PAT. And there's all kinds of correlation papers looking at TCPO2 and toe pressure. This is just direct duplex imaging. And the beautiful thing about PAT is you can see these vessels generally quite well on even diseased patients. So this patient has a low calcium burden. We see nice full color filling, and we can appreciate the flow direction. But PAT is just a small component. And Dr. Montero Baker and I are doing a lot of work around calcium burden and MAC score, so medial wall calcification, to say that we can now appreciate not only the calcium burden with 2-view X-ray, but also with ultrasound. So this talk is about decision making, and we can use PAT in all phases of care, in the outpatient, inpatient, and obviously the perioperative if they have intervention. But I also love it for surveillance after we've gotten these patients to a place of remission. So when we map the whole limb, we are going to again report out the PAT to the wound bed. And once we do this comprehensive arterial duplex, we then can make some decision making based on the comprehensive picture that we have. And I love this 6 fates of a patient with CLTI or maybe non-CLTI. So we're going to start with medicate and offload. This is a patient that has a neuropathic ulcer, and maybe the ABIs are erroneous or maybe they're usable. However, we know when we put the probe on the foot, this is class 1, and this patient would have a different direction of care versus this patient who has a long segment chronic total occlusion through the SFA pop. This patient, I think, deserves a great saphenous mapping. This patient would probably be better suited for bypass. And I've already told the surgeon that they have a 2.2 distal target and they have a very nice GSV. So, and I'm also noting the complexity of the disease in the SFA. So it's so complex and dense that the likelihood of crossing may be lower, and therefore bypass should be considered. And then we have these situations where these are short segment occlusions below the ankle. I believe that endovascular may be a better approach. You'll also note here that I'd like to say if access is safe, this is a nice antegrade access and go straight down to treat the tibial vessels. And you can see right away here the PAT is almost class 3 to that wound. Dr. Montero Baker and I do a lot of work with deep venous arterialization. And so these are complex patients at Hope Vascular and Podiatry in Houston, Texas. And this is a patient that I mapped for him that not only deserves a great saphenous vein mapping, but also deserves a full pedal venous workup, because this is going to be the new conduit when we do an arterialization. So looking at the disease pattern and patient presentation, I think can help guide us to what our appropriate treatment should be and intervention for this particular patient. And then, of course, in some situation, amputation and palliative care is also a better choice for that particular patient. So we have these nice decision-making options, but in CLTI patients, I really believe there should be an escalation of information that we gather from the arterial duplex ultrasound. So in regards to deep venous arterialization, there is a disease pattern that we should be looking at. These are no option, perhaps, patients that have an occluded posterior tibial artery and lateral plantar artery versus this disease pattern is very different. This is an occluded anterior tibial dorsalis pedis pedal arch disease. So in the world of DVA, we're now, of course, you all know about limb flow. There's also off-the-shelf techniques for deep venous arterialization. But in this type of disease pattern, I'm going to be mapping for Dr. Montero Baker the deep to superficial deep venous arterialization that's done endovascularly. Versus this type of disease pattern, Dr. Montero Baker chooses to do an open arterialization. And this is where we anastomose the great saphenous vein to the P3 segment of the popliteal artery. So the loop is opposite, it's superficial to deep. And I'm fortunate enough to work with him on these complex patients. So anytime we see a patient like this, I'm constantly looking at the larger picture of disease pattern to say that this patient may be better suited for a DVA. And the beautiful thing about ultrasound is that we can see the pedal venous anatomy very well. This is a healthy lateral plantar vein. We can see the valve structure in the pedal venous arch. And even in the setting of disease, this is an occluded lateral plantar artery. It's a white calcified circle with a very healthy lateral plantar vein that is very important for access for Dr. Montero Baker. he's going to access this lateral plantar vein. So I'm trying to map out this entire case so he can make a plan and know what he's getting into for this procedure. We also follow the patients post-operatively, just like AV fistula work. We're going to do a full comprehensive duplex ultrasound post-DVA and look at the entire pedal venous loop that we've created and use ultrasound to follow these metrics. And we're employing other techniques like venous pedal acceleration time, flow volume, to be able to track these metrics in the post-DVA patient. And really what we're looking for is recruitment and angiogenesis over time that we feel leads to wound healing and limb salvage. This can be a very successful procedure in certain situations. So for example, this patient had his DVA open for 4 months. It went on to occlude, but we see nice tissue granulation, and we can appreciate signals with ultrasound in the foot that indicate we have reached conversion, and this patient went on to heal really nicely. And so in summary, I think pedal acceleration time really in the future deserves a place in the Wi-Fi ischemia ring, working hard for correlation, but I do believe it adds value in these complex patients. So I'd like to thank Dr. Montero Baker for his ongoing collaboration and teaching. He's certainly a fantastic operator, and I really owe a lot of gratitude to him for his expertise. So thank you so much, everyone. Let's move on and talk about interpretation of results and really the application of pedal acceleration time, which I think is really important to be able to use this technique appropriately. So I want to recall that PAT captures collateral flow. So I love this because in the setting of complex infrapopliteal disease, this patient may be well collateralized and the PAT may be class 1 or class 2. So just remember that PAT captures all of the collaterals off the profunda, off the geniculates, all the way down to the foot. And so I love it in complex disease because it captures that collateral flow at the foot. So in regards to interpretation, to interpret correctly, we have to have correct technique. So this is an example of a first dorsal metatarsal artery obtained with poor technique. So the example on the left has a very small scale. We are overcalling the acceleration time at class 2. So this would be incorrect technique. We want to make the waveform really big. Now the example on the right is also incorrect. We want to measure from the onset of systole, not the baseline. So we have to, it would be incorrect. So we want to measure from the onset of systole to the peak of systole to have an accurate acceleration time. So the other thing I want to shout out is that we don't measure at the center of the waveform. It's just to the peak of systole here. So we're really after that interval change post intervention. So this patient has class 4 PAT. It's flat. We just can't measure it, but it's automatically class 4. The patient has intervention. We start to see a little bit of tissue granulation, and the PAT is appropriate at 88. That's class 1. And we've measured from the onset of systole to the peak of systole. This patient went on to heal just fine. Now I want to also show you some examples of incorrect technique, so we wouldn't be able to accurately use this data. So in this situation, the caliper is too far to the left. We want to make sure that the caliper is placed just at the base of the waveform, and the measurement hugs the waveform. So this is too far out. We want to make sure it's in really close. And in this situation, the waveform is too small, so we need to decrease the scale. And the reason the accuracy is so important is because we have this magic number of 180 milliseconds, or class 1 or class 2. Our data suggests that this is predictive of limb salvage and wound healing. So not only do we know the number for wound healing, we also have a number to use during intervention. We have an endpoint of when we've done enough to deliver blood flow to the wound bed. I'd like to share this case of a 57-year-old podiatrist. He has 3 wounds here, one on his heel, lateral foot, and toe, and he was told amputation. He is a non-smoker, diabetic. He has a very nice great saphenous vein with poor distal targets. He also has a high calcium burden in his 2-view X-ray. So I actually mapped him for DVA. But we decided to try endovascular revascularization first. So of course the SFA popliteal is clean as we would expect. Same with the TPT. And here we find a short segment occlusion that matches the ultrasound in the anterior tibial artery. We're able to cross the anterior tibial artery and use balloon angioplasty. Now this is a subjective view of a foot shot. And so when we use ultrasound, we have objective information. So the PAT improved from class 3 to class 1 with a simple balloon of the anterior tibial artery. We also looked at the lateral foot wound and saw that the PAT also improved to class 1. So within the first 30 minutes of the case, we've already addressed 2 wounds. And now we are going to focus on the perineal artery. So I'm going to be monitoring this lateral calcaneal branch to the heel wound. And we are going to get through with the wire and use atherectomy and balloon angioplasty of the perineal artery. Perineal looks very good post-therapy, and flow to the heel wound is class 1. So even though this is an AP foot shot of the heel, it doesn't look that exciting. There's not a wound blush, but with ultrasound, we prove that the PAT is class 1. We follow our patients all the way 1 hour post-operatively to show that the PAT is still in class 1 and we did not have any vessel recoil. The patient follows up in 1 month and the toe wound is healed, and the heel and the lateral foot wound are slowly healing. And that's despite all of this disease that was left. At 2 months, the lateral foot wound is healed and the toe wound, and look at this beautiful tissue granulation in the heel. At 4 months, he's doing really well, and he's healed at the end of 5 months. So I think there is a lot of information to gather from the use of ultrasound. We can follow these patients. If there's an interval change, we can see that with PAT. So this is when it gets difficult to use PAT in your decision making. There is a gray zone that we need to clearly further define. So in this patient, this wound is stalling. What is the PAT, and should we take the patient back? Again, we know that 180 is the magic number, but we also have to look at the entire clinical picture of the patient. So class 1 PAT is very easy. Class 4 is also very easy. But there is this zone right here between class 2 and class 3 that can be difficult to interpret and make a decision. So here's an example of a patient who had a guillotine amputation, and he was healing really, really well. His PAT was class 1, and his wound stalled, and his PAT changed from class 1 to kind of a higher class 2, and the flow velocity is almost to 5. This is a patient that then deserves an intervention, in my opinion. And same with this patient. This patient's PAT is just over class 3. And this patient should go ahead, and they had ischemic changes, should go ahead and go on to intervention. And then there's some tricky times on the table with Dr. Constantino or Dr. Montero Baker where the PAT is 168, but I want to show you this is a spasm signature. And we recognize this on the table. We can give intra-arterial nitro, and we can see the vessel start to relax. And then over time, when the patient is off the table, we can follow this patient. The PAT is still in class 2 range. Here's a nice case illustration of a patient who had revascularization below the knee. They had a guillotine amputation and were doing really well. The PAT is class 1, and we see very nice tissue granulation. Now, the A1C is a little high, but we're following this patient throughout the course of wound healing. The patient's healing really nicely. And then we see a stall in wound healing. Now I'm going to do an arterial duplex, and we see this high-grade restenosis of the popliteal artery, and that accounts for the interval change in PAT. So we do an intervention of that popliteal artery. The PAT now goes back down to low class 2, and the patient is back on track to heal and heals nicely. So, I always like to watch and see if there's an interval change in PAT over time. And I'm very proud to get this patient healed nicely. Here's a nice case of a patient that was told no option, and we can see why. He's failed multiple bypass, but he has CLTI with these non-healing toe wounds. And I think what's notable here is his profunda lesion. And so what we decided to do is use ultrasound on the table and do radial access and see if we can balloon that profunda. It doesn't look that remarkable angiographically, even with changing the projection of the C-arm. But with ultrasound, the profunda is 320, and post-balloon, it drops to 129. When I went to the foot, this is the pre-PAT, class 4. Post-profunda balloon, the PAT improves to class 1, and the patient goes on to heal very, very nicely. And this patient he was condemned to an above-the-knee amputation. So we really avoided amputation in that situation. So PAT can be sensitive and specific. It's inexpensive. We have ultrasound at our disposal, and it's widely available. And I hope you find this valuable in hopefully implementing PAT into your practice. So thank you very much. Honestly, all these patients deserve a full arterial duplex ultrasound to include the pedal arch. So if there is a wound, you should really do all 5 sites of the pedal arch. That's arcuate, dorsal, metatarsal artery, lateral, medial, and deep plantar. If there's no wound, it's okay to just get the arcuate and lateral plantar and move on. It's claudicat probably, right? So just, like George said, we got to think a little bit. You don't need to spend all the time looking at her medial plantar. First dorsal metatarsal artery. So her arcuate artery would be right here. And so you see it's kind of, hers is actually retrograde, kind of almost alternating. And I bet you, if we occluded the posterior tibial artery, look at now the flow it goes retrograde, or it flips over, because her pedal arch is intact. Her posterior circulation is just more dominant. Look at it, goes back to a retrograde fashion. So I've already proved that her pedal arch is intact. So for this one, you know, she has funky hemodynamics. It doesn't really matter for her. Can you just adjust this together? Yep. Because she's normal. I mean, she's totally normal. And lower the baseline all the way down. So we're just going to take a PAT here, just so it's measurable. So the key here is we want to drop our baseline down. We want this waveform to be really big. And then we're going to measure the onset of systole here all the way to the peak. And this waveform literally just needs to, that's probably a little false. It literally just needs to hug the waveform all the way to the top. So our PAT is 42, which is class 1, totally normal. So the landmarks is going to be the 4th toe. So what I'm going to do is put the probe right in transverse, right in the middle of the foot. The lateral plantar artery is in line with the 4th toe. So just put the probe in a transverse view, and we should see the metatarsal bones. And look, there's the lateral plantar vein. Okay, so if in your mind you triangulate the 4th toe, now I know where the lateral plantar vein and artery should be. Ginger, is there an indicator like green arrow I call here? There's probably 1.5. So I don't need to like work to stay on it like this. I literally can pick up the probe, indicator to the heel, go to the midfoot in line with the 4th toe, and just like aim a little bit laterally. And here's the lateral plantar vein. So I'm right in line with that 4th toe. And now we can put on color. Her vasculature is, there's her artery. And so it's just a more dominant vein. You can do a little calf augment and you'll see the lateral plantar vein. So let's just see if I obliterate the AT, yeah, or the PT, it compresses a little bit. So hers is just a little bit harder to see, but that's essentially the steps of the lateral plantar. Now the medial plantar, there's a tendon called the halus longus tendon. And so we basically go from the lateral plantar, just slide your probe medially. And there's a, this halus longus tendon, it's right here. So it's going to go just kind of angling with on the screen. And the medial plantar is going to lie superficial to that tendon. And for her, it's probably going to be very hard to see because she's so healthy. The medial plantar is generally very small in caliber and we'll get, yeah, tiny little vessel. Super, super tiny. So first met head wound, you would put the probe right here and get flow directly to that first met head wound because the medial plantar is supplying that. If there's a great toe wound, the most important PAT to report out is the first dorsal metatarsal artery right at the base of the great toe. If there's a 5th toe wound, then we're going to look at the 4th dorsal metatarsal artery, which is going to lie right between the 4th and the 5th toe. Again, hers is going to be so tiny, but there's you can usually image them, especially with
And there's no benefit to sitting them up, right?
I mean,
Would you get better flow or?
well, so if you sit them up with your feet,
criteria is-
yeah, it's going to be different. You're actually going to, you can show rest pain because your flow would improve with a dependent.
Right.
So I just do everyone laying down. Everybody image the perineal artery from this lateral approach.
Yeah.
Yes.
Okay, beautiful.
Yes.
Yeah, I think
That's actually the easiest way to
it's
get
the easiest way to see the perineal.
Yes.
Yeah, so just find the distal.
That's actually when I did
intertibial.
intraoperative. Whenever we went to perineal, we always went in.
Yeah, right there. Yeah. So So you just go about 1 or 2 finger breadths above the lateral malleolar bone. And then if you just scan up, you're going to see the fibula here, and then just go a little bit laterally, and here's the perineal artery distally. And this is where you're going to see that anterior communicating artery. It's going to go right here.
Yeah.
And you probably all have seen it, but this is a really nice view for it. There we go.
What probe is this?
This is the 12-3, just a standard probe that we use for carotid scanning. And so when we put the probe, the indicator of the probe is going to go towards the patient's head. We're going to put it down. So when you scan, remember, we just want to anchor our fingers down because we don't want to apply a lot of pressure. And so here we go. So right when I put this probe down, do you guys recognize what these are? The venous system.
Yeah.
So that is the medial marginal vein is our landmark. This is the cuneiform bone that you could feel, and this is the window, that soft tissue window. And so if you pan your probe a little bit medial, now I'm on bone. I have lost my window. So this is the cuneiform bone here. I'm going to turn color on. So right away, can anybody say which flow direction the arcuate artery is?
It looks like it's coming retrograde.
It is retrograde, yeah. So coming towards the probe in blue. So even when I look at that color flashing, it looks like biphasic to me. If I couldn't see anything, I can do a foot augmentation, and there's that foot perforating vein right below it.
yeah.
Do you see that? So that's what Lenny was saying. That's my landmark to see if I could find it. So then we're going to angle correct for this. It's okay to go in. Actually, let's go back here for a second. I'm just looking for the. Get this little flasher. This is probably the origin of the dorsal metatarsal artery. Okay. So this is true distal dorsalis pedis, bifurcation of the arcuate and dorsal metatarsal artery. Okay. And bring it in a little bit more. So I would just honestly angle correct because the vessel is diving. We're going to get a good Doppler shift at 0 degrees. I'm going to leave it below the line. Just raise your scale all the way up. We see about 4 cardiac cycles. And so this is an appropriate way to measure, right? The waveform's big. And so from here, we're going to measure. We're going to go to the time slope on this system. And we're going to precisely measure here from the onset here all the way so it kind of hugs the waveform. So our time is 108 milliseconds. So class 1, right? So when you had said earlier about compression, so this is being fed from the posterior circulation, right? And I'm not sure if I'm going to be able to obliterate it. Sorry, Ellen. Yep, there we go. I just changed flow directions. Yeah.
Cool.
So I'm forcing flow now down. Now it's alternating. Now it's antegrade.
So he has the posterior dominance in his foot.
Yes. Yes. So I'm just forcing flow down that anterior circulation. So now let's see if we can find the dorsal metatarsal artery. This might be, here it is. Sometimes you have to fan just a little bit. So this is his dorsal metatarsal artery. I'm just going to smooth his color out a little bit. So yes, we wanted to get it at its origin. It just comes off at a different angle, right? So here's the dorsal metatarsal artery. You can see it nicely. And so you don't want to stop there. Actually, I like to scan the dorsal metatarsal artery all the way out as far distally as I can see it. There we go. So I'm going to change my angle.
Nice and big.
It's huge, right? I mean, this vessel is so easy to
You
see.
can do an interdigital axis now.
Totally.
Yeah.
Look at that. Right there.
Look at beauty.
Yeah. So if
Elena access there.
Exactly.
So now I'm going to lower this back down. So that's not appropriate, right? So we're going to lower your color scale, make your waveform really big.
I'm really just trying to optimize my
Even bigger. There we go. And sometimes if the waveform's kind of funky, I actually just watch it for a second. Yeah, it looks normal, but I want to convince. If you were my reading physician, I'm going to want to convince you that I'm measuring. It's a clean waveform. And I think this is where the validation comes in. Sometimes images aren't so clean. So if you, this is incorrect, right?
Yeah. Mm-hmm. I like the previous waveform better.
That would totally work too.
Oh yeah, you see that little tip.
So this is also incorrect.
Oh yeah.
Correct.
Yep, so we have to go from the onset here all the way to the peak, so 92. But if you look at the variability, right? We're still in the same classification. You measured at 92, I measured at 96, we're good. Okay? So, and that's why it's okay to measure multiple waveforms. So that's it's basically the anterior circulation. Super easy, right? Now, what happens if there's a wound here? So I would put the probe, let's see if we can see it. I'm gonna put the probe right between the digital arteries here. More. You see this robust venous system, and that's why I think we studying it like crazy, because we can access these little veins. So if thank you so much. If I say my color scale is at 24, so I'm going to lower my color scale down. There we go. Lower it down. So when we talk about like target artery, if there was a wound on these toes, this is where I would go first. And yeah, I'm going to look at the whole pedal circulation, but this is outside of the 5 sites of the duplex, but it still can give, very interesting information. Because he has no wound, and we're not going to do anything about it, but I would definitely measure this velocity. We're kind of approaching, 5.
Yeah.
So you have to be careful what you do with it. Be careful. There's a lot we need to know about distal resistance. So because he's diabetic, what is this digit? Does he have, small vessel disease in the digits? Is that why it's resistive? So there's still a lot to know about these small pedal vessels. But I think knowing the entire pedal arch is very helpful, but also knowing what it is like out to the wound. Okay. So we did the anterior circulation. So now we're going to go to the bottom of his foot, and so we can put the probe in transverse. It's really just like smack in the middle of the foot, right? And right away, what do you see? Lateral plantar, right?
Oh, yep.
Yeah, is it right there? So we know we're in the lateral plantar because look, here's the metatarsal bone. And so from here, I'm going to use that metatarsal as my landmark. And we're just going to take the indicator of the probe. It's going to go towards his heel. And so now we're going to put it just at the mid-foot here. And ergonomically, this is kind of what Lenny was talking about. If we just put it in his heel, I'm just going to fan my probe laterally. We're going to start to see, there's your bone. There's the lateral plantar. And the plantar vein, the lateral plantar artery is going to lay right above it. And then there's the lateral plantar artery. And so you can squeeze the foot, you can help yourself out. If we wanted to see...
Can you show me transverse again?
Yeah, did you see the calcium? So his lateral plantar artery is right here.
Yeah, just
Oh,
a
wow.
little calcium there. Okay.
But in long axis, we saw it okay. Even though there's a little bit of calcium, it's okay. We're going to be able to penetrate. So you can follow all of these. That's a nice view. So when we talk about hibernating or underfilled, so because I'm doing a pretty hard compression, and if I really pushed, I can compress it. But when it's hibernating and there's no flow, you can compress that with like such little pressure.
Yeah.
You know
It's
that
like a vein.
exactly, but it's not occluded; it's just hibernating. So then if we turn this in long axis
I've
here.
accessed. I know it's a hibernating, and I'll access and find out it's a vein after I'm in.
Oh yeah. So nice view here. Sometimes it's tortuous like this. We're not going to get it in all this, all in one view.
Oh, that's
It's
big.
really beautiful, right?
Yeah, that's huge.
Yeah. So again, waveform selection, they're probably going to all measure somewhat similar. Just make sure we're being accurate, 72. So from here, it's literally just a slide of the probe towards the ball of the foot. You can study the entire vessel if you want. I just personally don't think it's necessary. So if we follow this lateral plantar right here, let's just watch it. The deep plantar is going to dive right there, okay? And there it's diving into the foot to meet that arcuate artery.